Welcome to our first video on low back pain. Let's begin. This is an overview of the topics we will cover. Let's start with spinal stenosis. With each diagnosis, we will be discussing the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. We'll start with spinal stenosis. As you'll recall from something like aortic stenosis, stenosis involves the narrowing of a space. In the case of spinal stenosis, this is a narrowing of the spinal canal. This may lead to nerve root or spinal cord compression. Here we see an image depicting spinal stenosis. Two magnified images are looking down at the vertebrae from above with the spinal cord in the center. In the bottom image, we see a normal spinal canal that is patent and unimpeded. In the top image, we see an area where the bony architecture has been altered, resulting in inflammation and concurrent spinal stenosis. In this condition, degenerative changes cause the spinal canal to shrink. Importantly, flexion of the spine widens the spinal canal and improves patient symptoms. Extension narrows the spinal canal, leading to worsened symptoms. Let's draw this out to solidify it as a distinguishing point for this diagnosis. Here we see two images of the lumbar spine and spinal cord. The image on the left shows the spinal column placed in extension, which occurs when someone is standing straight up. This narrows the spinal canal and causes increased pain in patients with spinal stenosis. The image on the right shows the spinal column during flexion of the spine, such as occurs when bending forward. This widens the spinal canal and results in decreased pain. The pathophysiology just described leads to the classic shopping cart sign, which is depicted here. In this, the patient's pain is worsened when they stand up straight or walk down a hill and improves when they lean forward, such as may occur when guiding a shopping cart or using a cane. Risk factors include anything that breaks down the joints of the spine and narrows the spinal canal. The primary example of this is degenerative joint disease, which includes things like disc herniation and facet osteophytes impinging on the spinal cord in patients with osteoarthritis. Increasing age is a risk factor as well, particularly being older than 60 years old. Space-occupying lesions such as a tumor can cause spinal stenosis. Any trauma to the spine, including surgery, can also bring this on. Finally, patients with certain skeletal diseases such as rheumatoid arthritis, ankylosing spondylitis, and Paget disease of the bone are more likely to suffer from this. Question stems about these patients will classically mention the shopping cart sign, which can also be referred to as a neurogenic claudication. This goes back to the pathophysiology described earlier. Because the spine is compressed, they can also get associated leg weakness, sensory loss, and numbness. So how can we distinguish a patient with neurogenic claudication from one with vascular claudication? Okay, this is a question that wants us to be able to distinguish two commonly encountered disease presentations. We'll use this table to outline some key differences, including the provoker of the patient's pain and the quality of the pain, and what the pulses are like distal to the affected area. In patients with neurogenic claudication, lumbar extension makes the pain worse. The pain is felt as numbness and tingling, and pulses are present bilaterally. There may also be weakness of the lower extremity muscles. In patients with vascular claudication, the pain comes on when the patient is physically exerting themselves, such as when going for a long walk or climbing stairs. This pain is more of a tightness or cramping sensation, often in the calf. Importantly, the pulses will often be diminished as a result of decreased blood flow through the stenotic vessel. Imaging is used to confirm the diagnosis of spinal stenosis. Because we need a high-resolution image that will easily distinguish soft tissue and nerves, MRI is the method of choice. Here we see an MRI of the cervical spine. Notice that the intervertebral discs have undergone degenerative changes. As a result, the spinal canal has become narrowed, which is consistent with a diagnosis of spinal stenosis. Conservative treatment is usually appropriate with physical therapy and exercise. Epidural steroid injections may provide pain relief. In some cases, surgery may be indicated. Next up is herniated disc. With the herniated disc, the disc material spills out and irritates nearby nerves. This almost always occurs in the lumbar spine, with the L5 to S1 disc being the most commonly affected. Trauma or degenerative changes are usually responsible for the disc opening up and spilling some of its contents. Here we see an image depicting a herniated disc. In the image on the left, we see a superior view of the vertebrae, spinal cord, and intervertebral disc. The intervertebral disc is made up of two layers. The annulus fibrosus is the strong outer layer of the disc, while the nucleus pulposus is a jelly-like inner layer of the disc. A herniated disc involves a tear in the annulus fibrosus and subsequent leakage of the nucleus pulposus. This leads to inflammation and irritation of the local spinal nerve and the symptoms of this pathology. Risk factors for a herniated disc include male gender, increasing age, trauma, and strenuous exercise. The clinical symptoms correspond with what occurs when a specific nerve is compressed. Because these tend to involve the lumbar spine, patients classically have low back pain that radiates down the leg along the distribution of the affected nerve. There may also be some paresthesias along the nerve distribution. This can be described as pins and needles sensation. The muscles may weaken and spasm because of the compressed nerve as well. The telltale sign that a patient has a herniated disc is a positive straight leg raise test. As a way of review, the straight leg test is a physical exam maneuver where the patient is lying supine and the examiner passively moves the extended leg through 60 degrees of motion. If this reproduces the pain, it is highly suggestive of some sort of nerve compression, such as can occur in cases of herniated disc. Clinical findings are often enough to be confident about the diagnosis, but an MRI may be considered in some patients. Providers need to be careful about this though, because many patients with evidence of a herniated disc on MRI are completely asymptomatic. Thus, imaging should only be used to support the diagnosis and not as routine screening. An ESR can be ordered if we are worried about infection. X-ray is indicated if we need to exclude a fracture. Here's an MRI image showing a herniated disc at the L4, L5 level. Notice the way the disc material is protruding into the nerve roots, which show up in white on this image. In a patient with a herniated disc at L5, S1, where might they experience pain and paresthesias? When the L5, S1 disc herniates, it often contacts the S1 nerve root. This spinal nerve feeds into the sciatic nerve, which is a large nerve that runs down the back of the leg. When this nerve is affected, patients get symptoms of sciatica. This means pain and paresthesias running down the back of the leg and often into the foot. Because the sciatic nerve is fed by multiple spinal nerves, a herniation of the disc between L4 and L5 vertebrae could give a similar presentation. Management of these patients often begins with NSAIDs to decrease the inflammatory response that occurs when a disc herniates. Patients should continue their normal activities and participate in physical therapy. Bed rest is not advised because it can slow down the recovery process. Epidural steroid injections may be beneficial. Rarely, these patients may go to the operating room for surgery to remove the part of the disc that has been herniated. This would only be indicated if the pain is persistent for more than 6 weeks and is causing significant impairment. Here's a table that reviews the causes of low back pain discussed in this lecture. A 61-year-old female presents to the clinic with a 1-month history of low back pain that radiates to her buttock and lower extremities bilaterally. She describes the pain as a burning sensation that comes and goes. She has moved her kitchenware to the bottom shelf because she experiences debilitating pain when attempting to reach the top shelf. There is no history of trauma. She was diagnosed with rheumatoid arthritis 13 years ago. Her temperature is 37 degrees Celsius, a respiratory rate is 18, heart rate of 82, and blood pressure is 141/77. On physical examination, the straight leg raise test is negative, and there is no point tenderness over the spine. She has normal strength and reflexes bilaterally. Which imaging technique would be most helpful in confirming the patient's suspected diagnosis? A. X-ray, B. CT scan, C. MRI, or D. No further imaging necessary. Before we can answer this question about what imaging study to order, we need to decide on the patient's suspected diagnosis. The patient's low back pain radiates to her buttock and lower extremities and is characterized as a burning sensation. This sort of sounds like a nerve pathology. The stem also mentions that the pain worsens when the back is extended, such as when attempting to reach the top shelf. The positional nature and quality of her pain, the fact that it occurs bilaterally, and her history of rheumatoid arthritis should have led you to the diagnosis of spinal stenosis. Now we need to decide on the best imaging technique for a patient with spinal stenosis. Answer choice C, MRI, is correct. MRI is great for seeing soft tissues such as nerves and the spinal cord. Answer choice A is incorrect. X-rays are more commonly used for suspected fractures, and this patient has no point tenderness over the spine or history of trauma to suggest that such is the case. Answer choice B is incorrect. CT scans are more commonly used for abdominal pathologies and suspected brain injuries. Answer choice D is incorrect. This would be the case if the patient had a lumbar strain, but there is no mention of an acute event or exercise triggering her symptoms, and they have persisted for 1 month, which is less likely in cases of lumbar strain. We would also not do imaging at 1 month if the patient had a herniated disc. This is a good idea as a potential diagnosis since the patient has symptoms of irritated nerves. However, the straight leg raise test was negative, and her symptoms are bilateral, making this less likely. So again, the next imaging test to confirm the diagnosis of spinal stenosis is MRI. And that concludes this section.